Hello, my name is Dr. Ayad. I'm a consultant neonatologist at Tawam Hospital. In addition, I'm a clinical assistant professor at the United Arab Emirates University. Today, we will talk about interesting topic, management of neonatal hyperbilirubinemia, implementing a new clinical practical guidelines. Before we start, I have nothing to disclose. The learning object for today, review, we will talk about the bilirubin production, and then we will cover physiological jaundice, outline the differential diagnosis for indirect hyperbilirubinemia, and then we will cover the differential or the differences between 2004 and 2022 new updated guidelines from American Academy of Pediatrics. We'll able to recognize the hyperbilirubinemia neurological or neurotoxic risk factors. When we initiate phototherapy, what does it mean? Escalator of care. And what about the exchange transfusion? When we start exchange transfusion based on the new current guidelines. This represented 2004, the old guidelines. And after 18 years, on August 2022, the updated practical guidelines was published for any baby with hyperbilirubinemia or clinical jaundice from 35 weeks or above. Let's talk about bilirubin production and physiological jaundice. As everybody knows, red blood cell destruction of red blood cell can end up hemoglobin or heme and globulin. Heme will convert it to the biliverdin. Each one molecular or milliequivalent or equimolar of the biliverdin will give you 1 carbon monoxide. This is the important concept. For each one biliverdin will give you 1 carbon monoxide. This is going to be a new technique to measure, or indirect way to measure the rate of hemolysis by measuring the entitled CO. Back to the biliverdin, it will convert it to the free bilirubin. The bilirubin here is fat soluble. Okay? So the bilirubin here is fat soluble, easy cross blood-brain barrier. At the certain level, it's work as an antioxidant. But when the bilirubin is raised, it can be converted to or can cross blood-brain barrier and cause curvature. And that's why it's important to keep the bilirubin in the certain safe levels. Then the bilirubin, the lipophilic bilirubin, attach it to the plasma protein and then take it all the way for conjugation process in the liver. At the time, the liver conjugate the bilirubin through the UGT1A1 with the uridine gluconide transferase, converted the unconjugated bilirubin to the conjugated bilirubin, which then excreted in the bile all the way to the intestine, and then excreted by help of the bacterial flora to the stool stercobilirubin or to the urine and give you the color of the urine. Why it's important to know these steps? Because by knowing the way of the RBC destructions and the bilirubin metabolism, it's easy to recognize the underlying cause of neonatal hyperbilirubinemia. We need to know that the RBC lifespan is short in the premature baby compared with the adult. The level of the uridine gluconide transferase 1A1 is 1% of adult level. So baby when they born, he has only 1% of the adult level, and it takes several months to reach to the adult level. So the conjugation process is very slow, and it's going to be even slower in the premature babies. Finally, from this process, the microbiome or the normal bacterial flora play an important role. And when baby born at birth, especially premature baby, they have less microbiome, and that's also affect the conjugation or excretion process for the bilirubin. The underlying cause of hyperbilirubinemia, when you have a baby with hyperbilirubinemia, the most common cause of hyperbilirubinemia is physiological jaundice. It's secondary to the number one, as we said, the lifespan of the RBC is very short, 60 to 80. So 60 in premature baby up to 80. And then in the adult is 120. So the RBC destruction is the faster. When the RBC destructed faster, the heme released. And heme is going to give you the biliverdin. And biliverdin will give you the bilirubin. So that's number one, is a turnover faster. With the decrease, secondary to decrease the RBC lifespan. Number two, the albumin take the bilirubin all the way down to the liver, but the conjugation process, the enzyme, as we said, is only 1% the adult level. So the process is a little bit slower, and especially in premature, even slower. So that's take time. So break down faster with a slower conjugation process, and that's why you have a common something called physiological jaundice. Usually a peak around 3 to 5 days of life. And the highest bilirubin usually around 8 to 9 milligram, the medium peak per deciliter. What about the pathological jaundice? Pathological jaundice, we will think about the previous diagram. Number one, we could have the destruction process, the RBC. That means increase the bilirubin production or decrease the bilirubin conjugation. The last one, increase the enterohepatic circulation. Two common etiology of the benign neonatal hyperbilirubinemia. Number one, breast feed jaundice. Number two, breast milk jaundice. The breast feeding jaundice, from the name feeding, that means insufficient feeding, and that's happen usually in the primary. And the mama doesn't have enough milk, it takes time. Baby inadequate oral intake, baby got dehydrated, and when a baby become dehydrated, increase the enterohepatic circulation and increase the risk of the neonatal hyperbilirubinemia secondary to the low calorie or low feeding intake. Usually appear early in the first week of life. So the clue is early in the first week of life. How to improve? By optimizing the feeding. In contrast, the breast milk jaundice from the milk itself, usually after the first week of life. The component of the breast milk that deconjugate the bilirubin and increase the enterohepatic circulation. So number one, deconjugate the bilirubin, the affect the glucuronation process. Number two, increase the enterohepatic circulation. Still, we recommend to continue breastfeed because usually it's not dangerous, never cause curvature. Okay? The more pathological hyperbilirubinemia, we said secondary to the increased production. So what we have the production? Number one, hemolysis. When the RBC distracted or distractions, fast distractions. It could be immune mediated, it's called isoimmune mediated, or non-immune mediated. It has nothing to do with the immune. The immune mediated, it can be Rh, ABO, or the other minor blood group. The Rh, when you have the mother negative, Rh negative, and the baby Rh positive. And at the time during pregnancy, some blood from the baby cross placenta, mom trigger antibody that cross the placenta and start attacking the baby's RBC. Again, RH incompatibility, ABO incompatibility. In this condition, the mom is O and has nothing to do with positive or negative, O, baby either A or B. Okay? The non-immune, usually distraction secondary to the defect in the soil wall, like spherocytosis, defect in enzyme like G6PD or pyruvate kinase deficiency, defect في الهيموجلوبينوبathy. Which one? I can hear beta thalassemia. No. Beta chain, either beta thalassemia or sickle cell anemia disease in the beta chain usually appear later on. Fetal hemoglobin is made from alpha 2 gamma 2, in contrast with the adult alpha 2 beta 2. So beta appear around 4 to 6 months of life. So beta never be the right answer. So either alpha thalassemia. Yes, alpha thalassemia. Okay, so that's number one, hemolysis. Number two, extravascular blood, extravasation. So you have birth injury, cephalohematoma, accumulation of blood, subgaleal hemorrhage. Those baby more likely to develop jaundice. Or baby born with polycythemia. We said the normal blood volume for babies is around 80 per kilo. If you have a baby with polycythemia, then more blood and then more distractions, or the distraction, the volume of total volume of distraction is going to be more. Then those baby more likely to develop hyperbilirubinemia. LGA itself also secondary to the infant of diabetic mother. So number one, increase the distraction or production, of the bilirubin. The second categories is decrease the conjugation or clearance of the bilirubin. It could be secondary to the prematurity. The enzyme is very slow, it's still immature. Hypothyroidism, which is usually cause of the late neonatal jaundice, also slow down. Baby with endocrine issue like hypopituitarism central, that everything slow down centrally, like hypopituitarism. Or you have a defect in the enzymes like Crigler-Najjar syndrome, which is two types, either deficiency or completely absent, type 1. The other part or type is Gilbert syndrome. Sepsis can also slow the enzyme. Okay, we discussed this. And the third part, increase the enterohepatic circulation. Increase enterohepatic circulation, like short bowel syndrome baby. Increase the bacterial overgrowth. Let's talk about 2004 compared with the 2002, the risk factor. Did they make any changes in the risk factor? So neurotoxic risk factor is the technically new to the 2022. The 2004, they have a different neurotoxic risk factors. It's categorically, or they place it as a hemolysis, asphyxia, significant lethargy, temperature instability, acidosis, sepsis, or hypoalbuminemia. In contrast to the 2022, they did not touch the hemolysis, but they remove all the other asphyxia, lethargy, temperature stability, acidosis, and they replace it with significant clinical instability. In the previous 24 hours, the baby clinically become very sick. That's considered risk factor. Sepsis remain the same, or hypoalbuminemia. When decrease the albumin level less than 3 milligram per deciliter, the free or fat soluble bilirubin unconjugated become freely in circulation in the blood, and then can easily spread, including the blood-brain barrier. So when we usually measure the albumin level, as we said, albumin, if we have a low albumin, then increase the risk of unbound serum unconjugated hyperbilirubinemia or unconjugated bilirubin. When you have an unconjugated bilirubin level is high, increase the risk of the neurotoxicity. Do I need to measure it in all baby? I need to measure serum albumin level? The answer is no. According to the 2022, we should start thinking of measuring the albumin when we reach the escalation of care. Again, the albumin level measured only when we reach something called escalation of care. What does it mean, escalation of care? Escalation of care means when you have a serum bilirubin, it's 2 milligram per deciliter below the exchange transfusion curve. Again, when you reach 2 milligram per deciliter below the exchange transfusion curve, then you can request the serum albumin level. Very good. Let's talk now about or on the phototherapy, how it's work, and what's the changes from 2004 guidelines to 2022 guidelines. Number one, the phototherapy, the recommendation used LED light. How it's work? The blue light from the LED light absorb the light, changes the bilirubin shapes and structure changes and become more of the soluble isomers. So changing the unconjugated bilirubin, absorbing the light, and then changing to the soluble isomer that excreted in the bile and become less harmful, less lipophilic, and does not need conjugation. So the mechanism of action, the LED light or the light absorbed the bilirubin, or the bilirubin absorbed the light and then converted to the bilirubin to the soluble isomers, different types, which is less lipophilic and does not need conjugation, and then will excrete easily in the bile system. The recommendation of the bilirubin, or sorry, the phototherapy should be at least 30 milliwatt per centimeter square. So the intensity of the light should be 30 milliwatt per centimeter water. So number one is 30. That's number one. The wavelength is around 460. So that can be board questions. The wavelength 460 plus minus 10. The light intensity around 30, and you should measure it. Using specific machine can measure the bilirubin density and give you number whether your machine is still powerful, still can be used. Before you use it, you have to look at the hours. Every light has a certain hours. So you have to check the manufacturer how many hours this light can be worked for. And then when it's expired, you have to replace the light. How far the phototherapy from the baby? It should be around 30 to 40 centimeters from the baby. So you have, and then when you have to read the phototherapy machine itself. It's mentioned the distance from the baby is around 30 centimeter, at least 30 milliwatt per centimeter water, and it measures how many hours. The moment from the manufacturer, when you turn it on, it will count how many hours, and every machine has that different hours. Hopefully it's clear. There's different types of light. According to the Cochrane Review 2011, there's no difference in the effectiveness in reducing the serum bilirubin between LED light, the halogen lamps, and fluorescent bulb. Although some article reported that the LED is more effective than the other. So here there's some controversy. But what we know, the fiber optic devices are less effective. Okay? It's very important. And the last AAP guidelines, they recommend the LED light. The second, when you place the light, you have to cover the surface area, which is one up and one down. That's what they call it extensive. The extensive, you have to measure it with 30 milliwatt, not about 2 or 3 machines around the baby. Because despite the higher irradiance, that's what they commented, double or triple phototherapy has no superior in clinical setting. It's more important, cover the surface area. In fact, it's more harmful if you exceed 460 the waves or 30 milliwatt, the intensity. So now, the AAP 2022, they recommend intensive phototherapy, required narrow spectrum LED blue light, number 1. The light outside should be around 460 to 490 nanometer. Anything above that, it's exposed baby to the unnecessary heat and potentially harmful waves length. So that's important. People ask me about the side effect of the phototherapy. They know phototherapy can cause diarrhea. No. Hyperbilirubinemia can cause phototherapy. No. If you use the extensive light can cause dehydration. Maybe some reporter in literature that can cause diarrhea or loose stool. Another concept is very important. When you place baby on the extensive phototherapy or intensive phototherapy, not extensive, intensive phototherapy, and the mom, she's breastfeeding, don't ask her to use the formula because you expose the baby or you're afraid the baby might have hyperbilirubinemia or might the bilirubin level increased. Interrupting phototherapy according to 2022 guidelines, interrupting phototherapy for breastfeeding does not impact the overall effectiveness of phototherapy. The only can be interrupted in one condition, the breastfeed can be hold or minimize it in case where the bilirubin at the escalator of care. So when the bilirubin is very high, 2 milligram per deciliter below the exchange level or very close to the exchange level, then yes, you can interrupt it and breastfeed or minimize the breastfeed. But if the baby requires just phototherapy, you should allow the mom to feed her or his baby. Feed her baby. Okay. So, in conclusion, is that there is strong evidence suggests that the bilirubin neurotoxicity does not occur until the total serum bilirubin level well above the 2004 exchange transfusion threshold. Again, for that reason, they look at the 2004 guidelines and they make the new recommendation after 18 years. Because the most of the evidence what we have right now suggested that the bilirubin to become neurotoxic usually way higher than the exchange 2004 exchange transfusion threshold. Number 2, why would they make these changes? There is potential harm from the phototherapy. And just this year, we have just recently published paper about risk of the or side effect of the phototherapy. And the concern about we are over treating babies, over separate the baby from the mother. Increase the anxiety with the parents. So since 2004, where's the evidence? Since 2004, there's 2 large population-based study, very large number enrolled, one in Denmark, the other in Northern California. In 2012, Denmark published from data, huge data, in infant more than or equal to 35 weeks correct gestational age, and reported among the whole data that we have, only 3 cases reported kernictures. 2 of them, they were ABO incompatibility, and 1 of them G6PD deficiency. The similar data in California, almost similar number of people or babies involved, enrolled, more than or equal to 35-week gestation. Only 3 cases of carnation reported. 2 of them secondary to the C6PD, and 1 of them patient was very sick in the IC. So what does it mean? Means the risk of or the incidence of carnation is very, very low. It's reported 6 per 10,000 infant with hyperbilirubinemia. So it's very, very low. What else? Has been also some emerging evidence that phototherapy is not entirely benign therapy. There's 2 studies published in 2006 and 2018 show that babies exposed to the phototherapy have higher risk of development later childhood epilepsy or seizures. And that's the 2006, they said there's no association with female, only linked with male. Similar reported, but they said higher in males than female. So both studies show increased risk of the later development childhood epilepsy and more in the male. Another data was inconclusive or insufficient evidence that babies exposed to the phototherapy are higher likely to have asthma or atopic disease, autism, skin lesion, childhood cancer, and affect breastfeeding family bonding. Babies receiving phototherapy have 1.2 to 1.6 fold increased risk of the hemobiotic cancer and solid tumors, or hematobiotic cancer and solid tumors. Phototherapy also increased risk of the neonatal nevi, melanocyte nevi, and those are important risk factor for occurrence of the skin melanoma. So it's not totally benign. Not only this, interesting study look at the waves absorption or the waves length absorption of the light, of the blue light. They found that riboflavin has a similar wavelength absorption like the bilirubin. So when you expose baby to the blue light, the biliverdin also affected by the light. And that's leading to the loss of the lipo or riboflavin in the body. And that can lead to the riboflavin deficiency, which is reduce the synthesis of active riboflavin adenosine dinucleotide. That's impaired the hydrogen delivery of the erythrocyte or the dinucleotide. And that's the impaired the hydrogen delivery of the erythrocyte. And that's aggravate at the end reduce the glutathione reductase and weakness the effect of the erythrocyte glutathione reductase, which might aggravate the hemolysis. The same what we see it in the G6PD. So what's that? Let's go over the methodology that was used to make the new phototherapy and new exchange threshold curves. We'll start with the phototherapy curve. So that's the old guidelines. As we know, as we are everybody familiar with the old one, we have 3 lines. We have the first, the dots line, which for full-term baby more than or equal to the 38 weeks and well. The second line, so that's the low risk. The second line, infant with medium risk. Those full-term more than or equal to 38 weeks with risk factor, or premature baby and well. Premature, that means 35 to 37 weeks plus 6 days. The last line, the solid line, is for the premature and well, which is considered the high risk zone. So what they did, number one, if you have a no neurological risk factor. So we have a 2 phototherapy line, the new guidelines. One for the no neurological risk factor and the other for the neurological risk factor. For those with no neurological risk factor, what they make for full-term baby infant, full-term baby infant, they move the curve, the low risk, the full term, 40 weeks, they move it. So this is so we know that if the baby above this, we will start phototherapy for full term. They said no, we will move it 2 milligram per deciliter above the 2004 low risk threshold. So they move the low risk zone 2 milligram per deciliter higher. So used to start phototherapy here, now you have to go above 2 milligram per deciliter higher than the old line. If you have a preterm baby, 35 weeks, the new guidelines, they move it only by 1 milligram per deciliter above the old 2004 guidelines. Anything between the 36 and 39 weeks, they moved in between. That means only by 1 milligram per deciliter. So let's give example. If you have a baby who's premature baby, 72 hours old, and the bilirubin level 15. By looking at the old guidelines, it's at the phototherapy level or phototherapy threshold. With the recent guidelines now, so let's talk about the new guidelines before we talk about this. So new guidelines, you can see now there is multiple dots. That represent different gestational age. So you have to look at number one, this phototherapy line criteria for no risk factors. So number one, baby has to be without risk factors. No sepsis, no G6PD, no evidence of hemolysis, etc. And baby clinically well. And you look at the gestational age. If we said 35 weeks, corrected gestational age, the last one, 72 hours, and the bilirubin is 15, we are far below the phototherapy line for 35 weeks, and even farther for those at 37-week gestation. So you can see here, we avoid start the phototherapy in this baby compared with the previous or old 2004 guidelines. Now, if you have at least one risk factor, there is another curve for phototherapy curve for those with risk factor. We said in without risk factor, they move it and they increase by 2 milligram per deciliter above the low risk. Since there is risk factor, we shouldn't have. Since there is no risk factor, we shouldn't have the old low risk zone, because either 38 medium risk, that means 38 with risk factor, or 35 weeks and well. So if you have the difference now in those with the risk factor, they move it only by one for full term baby and only by one in the premature baby, and in between the rest. And that's the new curve. As you can see, dots represent the gestational age. And here they mention phototherapy with neurotoxic risk factor. Another changes in the new guidelines, they make two exchange threshold curves. In 2004, there was only one for both groups, risk or without similar. But in the new 2022, they separate the exchange transfusion curve for the baby without risk factors or without neurotoxic risk factors, and there is separate curve for those with neurotoxic risk factors. So that's exchange transfusion with no risk factors and exchange transfusion with neurotoxic risk factor. And again, depend on the gestational age. You need to follow each line based on the gestational age. In the XY, in the y-axis, the total bilirubin, and here the age of the baby by hours. Let's talk about now how we evaluate the baby with the neonatal jaundice. According to the AAP guidelines, the latest AAP guidelines, all infants should be visually assessed for jaundice at least every 12 hours following delivery. So the nurses, physician, they should assess the baby regularly each time someone entered the room. They should have a clear assessment for the visualize the baby's color. Once you notice the baby or the nurses discover the baby clinically looks jaundice, you should measure either transcutaneous bili or serum bili. Now, as we said, the new guidelines, they mentioned they add the transcutaneous bilirubin or serum bilirubin, depend on your institution. If you have it available, transcutaneous bili, use it. If you don't have it, then use the total serum if you notice the baby looks clinically jaundice. Okay, so we said visually, you should visualize the baby at least every 12 hours from the time baby born. But when we consider mandatory screening, every baby should be screened between 24 to 48 hours after birth and before discharge home. If you are in the center where 24 hours and send baby home, you should measure it at least prior to discharge baby home. If there is no clinically, there's no risk factors. So there's no neurotoxic risk factor, and baby clinically will at least one measured prior to discharge home and documented, either transcutaneous or serum bili total. And we mentioned total, not indirect. You should measure total bilirubin level. Transcutaneous bili that studied in 2000 extensively in the United States, Traeger and Phillips. But you can use any machine as long as you have a good validated data in your center. There is good, somebody can ask me, how good the transcutaneous, what's the differences between transcutaneous and serum, total serum bilirubin? The AAP, the last version, answers this question. Is good relationship between transcutaneous bilirubin measurement and the total serum measurement, which generally within 3 milligram per deciliter differences. And that's correct when the total serum bilirubin below or equal below or less than 15. If you have a serum bilirubin, transcutaneous bilirubin more than 15, it's become less accurate or less validated. So anytime you have transcutaneous bilirubin 15 or higher, you should send serum total bilirubin. Below 15, the result is the correlated within 3 milligram per deciliter. The other condition, rather than 15 milligram per deciliter, if you measure the transcutaneous bilirubin and you find it exceed or at the phototherapy level or within 3 milligram per deciliter, the phototherapy treatment threshold, very close from the phototherapy, you should send serum bilirubin. Confirm it. Anytime you have the transcutaneous bilirubin close to the phototherapy level, you should send serum. Or if you have a transcutaneous bilirubin more than or equal to the 15, you should send serum total bilirubin. Based on what? What's the evidence? Based on the study published and found the correlation between transcutaneous total bilirubin and transcutaneous bilirubin is within 3 milligram, and the moment the serum total bilirubin, the transcutaneous bilirubin past the 15 or higher than 15 milligram per deciliter, the difference between both, it become wider or become less reliable. Remember, if you measure transcutaneous, you can continue measure transcutaneous and see the rate of rising between the transcutaneous and transcutaneous. Or serum total bili, compared with serum total bili. You cannot compare transcutaneous and then subtract it from the total. If you have one reading transcutaneous, the second reading of total, then you say, okay, and the rate of rising 0.2. It doesn't work. So either you take transcutaneous, and see the differences, or total bili versus total bili. So you have a total bili, you continue to measure total bili, or if you decided to see the differences, you have to compare either transcutaneous with transcutaneous or total bili with total bili. If the baby exposed to the phototherapy, you cannot use transcutaneous bilirubin within 24 hours of off phototherapy. So you have to wait until 24 hours of phototherapy, then you can use the transcutaneous. As long as the baby inside the phototherapy, you shouldn't use the transcutaneous bilirubin. The exception if you use the cover. Certain machine like Philips, they have a window cover. So before you start phototherapy, you put the baby on the cover over the skin and you close it. So it's going to be covered. It's not going to be exposed to the light. Then you can open it, use it, turn off the light, open it, use it, and then turn it off or cover it back. The studies of the transcutaneous bilirubin measurement on the skin that has been covered by the opaque patches, like you can see in the picture, during phototherapy have yielded a mixed result regarding accuracy, and that's bare statement from the AAP. So still we don't have strong recommendation because of the mixed result regarding the accuracy. So routine, let's assume that you notice the baby or you have a baby with clinically looks jaundice and you have enough concern. So this baby, before you start phototherapy, you should have the look at the good history, ask about mom RH, mom blood group. You request baby type and screen, neonatal type and screen, blood group of the baby. Kumis is important to figure out whether this is immune mediated versus non-immune. If Kumis positive, that means there is immune mediated, either ABO or RH or minor. If Kumis negative, then and there is evidence of hemolysis by drop in hemoglobin, increased retic count, carbon monoxide is high, or carboxyhemoglobin and blood gas is high, then you have evidence of hemolysis. With Kumis negative, that's non-immune mediated hemolysis. Again, if you have anemia or higher retic or any other evidence of hemolysis like carbon monoxide rising in entyl CO2, or you use the gas where you measure the carboxyhemoglobin. If you find it very high, that means there's evidence of hemolysis. And Kumis negative, then that's the hemolysis secondary to the non-immune mediated. You always request CBC and smear, and total, as we said, bilirubin. If the baby responds poorly on the phototherapy or close to the exchange at the escalator of care, then you should add retic count, G6PD, sepsis, thyroid. G6PD, this one, if you are in the Middle East or you have, maybe you can use a different strategy. In my center, we do screen G6PD because we have very high rate of G6PD. So here is that, depending on the institution. So what's the rate of rising when we consider significant? The rapid rising of the rate of increase more than 0.3 milligram per deciliter per hour. So if you see the difference between two bilirubin in window of 12 hours, 6 hours, 4 hours, 2 hours window, and in the first 24 hours, and the result of the rate of rising differences more than 0.3 milligram per deciliter, that's significant enough to start phototherapy. After 24 hours, the rate of rising to consider significant is more than or equal to the 0.2 milligram per deciliter per hour. And that's exceptional if you have evidence of hemolysis. Again, you can also indirect measure the entire carbon monoxide. Remember, we said that in each biliverdin, you have 1 milliequivalent of the carbon monoxide released. That's the carbon monoxide you can measure by the entire end-tidal CO production. Specific machine. Okay. Let's assume that you admit the baby, you decided to start baby on phototherapy. How often I need to measure the bilirubin level? AAP stated very clear, you should measure it within 12 hours after start phototherapy. And again, depend on whether there is evidence of hemolysis or no. If you have ABORH, maybe you need even closer than 12 hours. You should do it even 2 to 4 hours, especially if you're close to the escalation of care. After starting phototherapy, let's assume that you have a couple of the reading, the bilirubin was stable, then you can space the measurement guided by, depending on the age of the baby, presence of the hyperbilirubinemia risk factors, evidence of hemolysis or neurotoxic risk factor, evidence of hemolysis, etc. So initially every 12 hours, and then depending on the rate of rising, depending on the risk factor, age of the baby, you can space to the Q18 or Q24 hours, depending on the baby's condition, case by case. Let's talk about the new terminology called escalation of care. We discussed about escalation. We defined it as when the serum bilirubin or total serum bilirubin is 2 milligram per deciliter below the exchange transfusion threshold. It's always use the total serum bilirubin as a definitive test that guides management, not only indirect. You should include it direct, everything, the total. So when you are very close, you should change your management from passive to the proactive because you are very close from the exchange transfusion. And if you are in the center that they don't have the exchange transfusion is not available, you should contact the neonatologist and transfer baby before too late. So here very clear stated, if you are at the escalation of care, if you are in the floor and you have a NICU where exchange can be done, you should transfer baby to the NICU. If you are in the center, there is no exchange transfusion, you should contact the referral center or tertiary center and should refer the baby as soon as possible. Okay, so we discovered this one. The second, I did not talk about it. If the baby on phototherapy, please don't start fluid. The new phototherapy line has nothing to do. If you are follow the guidelines, it has nothing to do with dehydration. So don't start phototherapy unless baby has evidence of dehydration. The only condition, the only one condition, and very clear stated in the AAP guidelines, the only one condition you start baby on IV fluid if the baby at the escalator of care. You are very close from the exchange transfusion, then you still can feed the baby, but you start IV hydration. You should request all the labs, including electrolytes, serum albumin. Imagine, do you remember when we said, when we measure serum albumin at the escalation of care? And when considered, another question, when consider IVIG? When COMS positive, the answer is no. When you have evidence of hemolysis, AB or RH, the answer is no. The only condition you start escalation of care, the IVIG, when you are at the escalation of care. When you are very close from the exchange transfusion. And number two, and that's and is important, when you have evidence of isoimmune hemolysis. So COMS should be positive. If you have one time COMS negative, you should repeat it when baby at the escalation of care, because it might be first time negative, maybe turn positive. So you have to, if you have evidence of fast, rapid rising in the bilirubin, you should concern about hemolysis. And the time you should repeat the COMS, even though you ordered, you should repeat it again. At least in my experience, I saw two where a COMS negative and then turn positive. And only that condition you can give the IVIG 0.5 to 1 gram per kg over 2 hours if you have evidence of isoimmune hemolysis. And not only this, if you admit baby under escalation of care, you should actively and frequently examine the baby neurologically. You have the neurological assessment more often. Now, we discuss about escalation of care. Do you remember this one, the old follow-up guidelines? It's no longer 2004. They replace it with time of follow-up after exchange. And the time to follow up after exchange is depend on the bilirubin close to the discharge. How far from the phototherapy line? When you decide to send the baby home and you have a serum bilirubin or total serum bilirubin, how far from the discharge is give you category. You subtract it from the phototherapy threshold. And based on the level and age of the baby, there's clear evidence guidelines when you need to repeat the bilirubin. Okay? So here, for example, if the baby, and that started after 12 hours of age, if you have the difference between the bilirubin total and bilirubin at the phototherapy level, how far from phototherapy level was less than 2 milligram per deciliter, and the baby less than 24 hours, don't discharge the baby. Consider phototherapy. And measure total serum bilirubin 4 to 8 hours. If baby older than 24 hours, continue measured, and there is instruction very clear. And similar for the rest. There is a new recommendation now on home phototherapy. When you consider send baby home and you requested home phototherapy, I don't think in UAE we don't have it, the home phototherapy yet, but in the United States it's available. So the insurance can pay for the phototherapy. The parents, they can take the phototherapy home, and that's help decrease the anxiety from the parents. But it's very clearly stated it has to be under certain conditions. Number one, baby's full term or more than or equal to 38-week gestation. Baby old enough more than or equal to the 48 hours. Clear from the history, no neurologic or no neurotoxic risk factors. No previous phototherapy. Baby never starts phototherapy before during this pregnancy, or sorry, during this delivery. The bilirubin level is less than 1 milligram per deciliter above the phototherapy threshold. It's not super high. It's just within 1 milligram per deciliter above the phototherapy. Clinically, baby has to be well. You should use the LED light, and availability of the testing the baby on the daily basis. So there's certain condition. Baby has to be full term baby, well baby, old baby more than 48 hours, never get phototherapy, bilirubin very close, or phototherapy bilirubin level very close from the curve of the threshold phototherapy within 1 milligram per deciliter, and you have the availability of the LED light, plus you have the way to measure the bilirubin on the daily basis. If this condition is available, then you can send baby home on the home therapy, home phototherapy. Also, the new guidelines describe very clearly what does it mean rebound hyperbilirubinemia. Rebound hyperbilirubinemia, that means the moment you stop bilirubin, stop phototherapy, the bilirubin reach again the phototherapy threshold within 72 to 96 hours after discontinued treatment. So when you stop the phototherapy, raising the bilirubin level back to the phototherapy threshold within 72 to 96 hours, that's when we call it rebound hyperbilirubinemia. When this condition happens, when you have a baby who is younger, premature, younger gestational age, evidence of hemolysis or the neurotoxic risk factors, early when you start phototherapy lines, and you decide to stop phototherapy where it's very close from just below the phototherapy line, you stop the phototherapy. So according to the data from the literature, that those baby at higher risk of the rebound hyperbilirubinemia. So the option to stop the phototherapy in order to prevent rebound hyperbilirubinemia, number one, when the total serum bilirubin is 2 milligram per deciliter below the starting treatment threshold. So if you start baby on the phototherapy and the bilirubin was 15 in our example, previous example, then you can stop it when the bilirubin curve is at 13, 2 milligram below the starting phototherapy. As we know from here, every day the bilirubin, regardless, even it might be below phototherapy, but every day it will increase, or it might increase. That's normal, physiological. But it has to be, in order to stop treatment to avoid the rebound, better to wait until it drops before starting 2 milligram per deciliter before the starting number or threshold. Where does evidence come from? This evidence comes from the retrospective cohort study published in 2019, enrolled data from 2012 to 2014 in those baby more than or equal to 35 weeks gestation in Kaiser Hospital in California, North California. They enrolled 7,000 baby infant treated with phototherapy. They found overall around 4.6% of babies, they have a rebound hyperbilirubinemia. And the result of their data, that rebound hyperbilirubinemia can be predicted by simple two-variable model consistent of gestational age and starting the threshold, ending total serum bilirubin differences. And the bilirubin level 2+ below the starting threshold carry an estimated, they calculate the estimated rebound bilirubinemia or probability that baby will reaching the phototherapy. They have the method to calculate what's the probability that baby based on collective data, and they found if the baby full-term baby more than 38 weeks, the probability of this baby will develop rebound drop from 4.6% to the 2.5%. Increase to the 10.2% if you have a baby premature, less than 38 week gestation. So it's jumped from 2.5 all the way to the 10% if you have a premature baby. In order to decrease this number in premature baby, they calculate the probability. So here we said 2 milligram per deciliter from the starting threshold. If you decrease to the 5.5 millimeter from the starting threshold, you drop the probability from 10.2% to the back to the 2.5%. So baby full-term baby, you can stop the bilirubin when the 2 milligram per deciliter below the starting threshold. In premature baby, you can wait longer. How to calculate? Do I need to have this graph with me for all different graphs? The answer is no. The AAP have a good website called BellyTool. BellyTool. It's very clear, very sharp website. You just have to put the date of birth, the age of birth, or the time of birth, and then the date of collecting the lab serum bilirubin, the time. So it's calculated how many hours the baby old, and then add the gestational age of the baby, and they ask you whether there is neurotoxic risk factors. Once you answer yes or no, then it will come with nice graph, and it will report it where your bilirubin level in those graphs, and then come with the beautiful recommendation. Do we need to start phototherapy? Yes or no. Escalation of care? Yes or no. Exchange transfusion? Yes or no. And here in this example, just we put random data, and it gives you clear instruction even when you repeated the phototherapy bilirubin level. If you did not, if you are is not qualified for phototherapy, it will come with the recommendation. The one we said they measured from the last bilirubin with difference between the last bilirubin and the phototherapy level, how far from each other, and then the differences they will calculate it and will give you the estimated when you're gonna repeat the labs. In premature, unfortunately, the guidelines is only for 35 weeks and above. For those less than 35 weeks, I use the Bilirubinemia that came from Stanford Children's Hospital, Bontani, the same one with one published data from 2004 guidelines. They have a very good app that you can call Bilirubinemia. You can write it down, corrected gestational age. So it's not the gestational age, correct gestational age, and then the total serum bilirubin. It has to be older than 48 hours, and it will come with the beautiful recommendation. What about the IVIG? We mentioned earlier that IVIG recommended useful for infant who has ABO, RH, hemolysis, or hemolytic disease. And it has to be close to the, or at the escalation of care while baby on the intensive phototherapy. Take home points in summary: start using 2022 guidelines to minimize the phototherapy use. Recognize the neurotoxicity risk factors and extremely important. History, and examine your baby. Avoid subthreshold phototherapy as it's not completely benign therapy. Avoid routine use IV fluid unless baby at the escalation of care or there is clear evidence of hemolysis. Focus on optimizing the enteral intake instead of the IV fluid. If the baby meets escalation of care, you have to be proactive. You have to call the neonatologist if you are in the unit, in the floor, pediatric floor, transfer baby to an ICU. Or if you are in the level 2 or 1 NICU, you should transfer baby to the tertiary center. Thank you so much. I hope it's clear.